Welcome to the next episode of Endoscopy Essentials. Today we have a topic which raises the heart rate for many endoscopists, GI bleeding, and I'm very happy to have Ian Gralnek from Israel, the current president of the ESGE. Welcome.
Thank you. It's a pleasure to be here, Thomas.
And thank you for helping us with this topic. So let's start easy. A patient is coming to a hospital. So what's required as a hospital service? A team on call who should be that, ICU where you should do it. So what should the best logistics be?
So if we start with the gastroenterologist, there really should be a 24/7 on-call gastroenterologist or endoscopist who's able to treat GI bleeding every day of the week, including weekends, of course. And really, ideally, there should be an on-call endoscopy nurse. Mm-hmm. So a nurse that knows how to deal with endoscopy, knows how to treat hemostasis along with the gastroenterologist or the surgeon who's ever doing the treatment, and not needing to take a nurse from the ICU or from the emergency department.
OR.
Or the OR, exactly. And that's actually written in guidelines at this point, but that does not occur in many places because of multiple different reasons. But in the ideal world, that's the way it should be.
Should it be more strongly supported? Because I think that's a very risky endoscopy, right? And it's happening during the night. And if you don't have a nurse, sedation has to be done. So
yes. Although today, I think that less and less we absolutely need to do middle of the night endoscopies. Current recommendations for at least suspected non-variceal upper GI bleeding is to scope those patients really within 24 hours from the time that they present. I'm talking about ambulatory patients. If it's suspected variceal bleeding, the current recommendations by the Europeans, by Bavino, by the Americans, is within 12 hours of presentation. However, there are now questions whether that's really necessary. And we don't have a lot of great data, but there are some already really proposing that maybe even suspected variceal bleeders, we could wait up until 24 hours because there's some data to show that earlier intervention doesn't really do anything clinically.
So you start with medical treatment then?
Start with medical treatment. This classically begins in the emergency department. In an ideal world, you need to initially start with IV fluid resuscitation. That's really key. And to paying attention to what their comorbidities are. It is very rare that a patient with GI bleeding dies because of exsanguination. They go down the bad road because of other comorbidities, especially cardiovascular comorbidities they may have. And also there's data to show that if we don't adequately resuscitate them and we don't adequately pay attention to those comorbidities and we scope them actually too soon, they can actually do bad things and have worse outcomes.
Exactly. So trust the ICU people or the emergency department people?
I think we need I think we need to try and trust the emergency department people more. And again, this comes down to really what are the services around the world that are providing the emergency department. If you look at the United States, it's emergency medicine physicians. If you look at my country in Israel, it's not that common to have, regularly trained emergency medicine physicians. The emergency departments are often divided into the internal medicine side and the surgery side. GI bleeders most often go to the surgery side. So it's different. Now you can get away or facilitate the management if you have some type of a clinical care pathway that is known to the emergency physicians of how to treat these patients when they present.
So at least in cities, there should be specialized centers? Is that the case in the US, for example?
No.
Bleeding is brought everywhere?
Because if people are living outside in the countryside, they may present to a regional center that may not have an on-call gastroenterologist, and they may be transported to a larger city to a hospital that may be a level 1 trauma center that does have that type of expertise.
So I think the message for us endoscopists, there's a lot going on before we even are called, maybe.
Oh, absolutely. Yeah. There should really be, whether it's a written checklist or a checklist in your mind, that we need to be going through prior to introducing the scope. That's very important. And that can be things such as the IV fluid hydration to resuscitate the patients, decisions being made whether patients need to be transfused with packed red blood cells. And you know, today we've gone more to a restricted blood transfusion policy based upon randomized trial data that we think it's safer and better for the patient. Patients ideally should be risk stratified at the time of presentation, and the most common risk stratification tool is the Glasgow-Blatchford score. So patients scoring 0 or 1 is a very, very low risk of needing any type of intervention in the hospital. And the current recommendations from guidelines is you can actually discharge those patients as long as they're safe follow-up to home. And we also know that Glasgow-Blatchford score of 12 or more are much more high-risk patients. The other things we need to be doing is most places will put those types of patients on an IV PPI. Do we have great evidence that that actually changes anything clinically? Probably not. There was a meta-analysis that was redone just a few years ago of all the randomized controlled trial with several thousand patients. And in terms of really, does it impact rebleeding? Probably not. You may discover more high risk, or you may have lower risk lesions because of the effect of the PPI, but we all do it anyways, is the bottom line.
Okay, so you're sitting at home, you're on call, and you get the call, there's a bleeding patient. Of course, there's a number of questions you ask. Some of them you have already mentioned. How is it in daily life? It's probably easier to stratify between suspected variceal and non-variceal bleeding.
Usually,
Are
but
there any pitfalls?
It's not 100%. I mean, the patients who come in who have known liver disease, who may have bled from the past from varices, known alcoholics or intravenous drug abusers are going to put you more into the side of this is possibly or higher likelihood of variceal bleeding, but that's not 100%. If we're talking about suspected variceal bleeding and preparations, the other thing we always need to remember is that we should be in those patients where we're suspecting to start a vasoactive agent in the emergency department. And these patients need to be given IV antibiotic, preferably ceftriaxone, prior to endoscopy to decrease the risk of SVP, as well as there's data to show it decreases mortality. And that can be given on a once-a-day basis for up to 7 days.
And variceal is, I understand, more urgent than non-variceal to some extent, although, as you mentioned, we start to realize that maybe sometimes less is more.
We think so. We think that, like I say, it's guidance, right? So guidelines are guidance. There's actually just some data that was presented here at the UEG Week 2024 that shows that there may not be an improvement of outcomes. The other thing that was very interesting is that they looked at patients who are endoscoped within 6 hours of presentation. Now, this is from a database, so it's not a high level of evidence, but those patients seemed to do worse. And that's also in the guidelines. It's not recommended to scope patients too soon because we do know that often they are undertreated for their medical conditions, resuscitated hemodynamically, and they can have poor outcomes, worse outcomes.
It's funny because, for example, in our country, the guidelines for reimbursement are that the nurse has to be in the hospital within 30 minutes. While we could wait for 12 hours, we now learn, right?
Yeah, well, reimbursement we know often lags behind what the current evidence shows. Yeah.
Okay, so you get that call, you check everything, and then, but at the end you have to rely, if everything is done, on the assessment of the emergency person, how stable the patient actually is.
Yeah, exactly. And
let's say it's 6 p.m.
Well, what I tell my house staff and what I tell when I give lectures is that because sometimes there's pushback from the emergency department. You need to scope this patient now. And you don't want something to happen where they're saying, GI refuses to do this. Then you need to go in physically. You need to see the patient. You need to evaluate the patient. And you need to document in the medical record the evaluation. And that's fine if your evaluation is A, B, C, D, this patient does not require immediate endoscopy. This is what should be done. We will plan to do endoscopy, whatever, 6 hours from now or 12 hours from now. That's fine. But if you're on call, you may need to make that trip to the hospital and not necessarily do the endoscopy, but do the right thing for the patient as well as do the right thing medical legally.
So you have decided that you will do the endoscopy at some stage, maybe same evening, maybe next morning.
Mm-hmm.
What direct preparations? Nasogastric tube? No.
No. There's no really good data that alters what we are doing. It's an uncomfortable procedure. Patients don't like the procedure. We also know that even if you get bilious return or clear fluids on the NG tube, you can miss up to 15% of high-risk endoscopic stigmata of bleeding. Mm-hmm. So it really doesn't change management, and there's no real reason to do that, although it's often the favorite thing for some of our colleagues to do in the emergency department, despite that.
But it should not be done.
It should not be done. Yeah. There's really no good reason to do that, yes.
So gastric motility like erythromycin, should that be given?
It can be given. The current recommendations are if you suspect that there may be residual blood or clots in the stomach, it would be a good idea, as long as the patient is not allergic to macrolide antibiotics, as long as the patient doesn't have a known QT, lengthened QT interval. We do give it in those situations. We don't routinely give it. The current recommendations are to give 250 milligrams IV, anywhere from about 30 to 90 minutes before you want to put the scope in. It is a motilin agonist. It does increase gastric emptying, and the data show that at least it provides better visualization in the stomach, and it may prevent the need for repeat upper endoscopy. It has not been shown to change things like an impact on rebleeding or mortality or need for surgery, things like that.
But the conditions are a bit improved.
The conditions are definitely improved. Now, one of the negatives is that I've heard from multiple places around the world that erythromycin is not readily available, that they can't get it. It may not be in the emergency department. They may not have it even within the hospital pharmacy. So there are some places that may use Reglan instead. It's not as good as erythromycin. I've heard of even people trying azithromycin, and there's no data as far as I know on that, but people will do things like that. But erythromycin, if you do suspect that there's residual blood, absolutely go ahead and give it if there's no contraindication.
So now comes the big and difficult question, sedation.
Okay.
Anesthesiology.
I tell you, we don't have any hard and fast rules of when we need to do the patient, let's say after hours in the operating theater with anesthesiology coverage. We oftentimes, if we feel that the patient otherwise healthy, they don't have really many comorbidities, we will actually do those cases in our endoscopy unit itself.
But that's also the case which will be done next morning.
Yes, exactly. Yeah. The real urgent case where you feel that the patient needs to be done sooner, then those cases we will do with anesthesiology coverage. Now that doesn't necessarily mean that they're intubated, okay? So endotracheal intubation, there's actually data to show that those patients actually may do worse when they're endotracheally intubated. The current recommendations, both for non-Variceal as well as Variceal, is that when should you consider endotracheally intubating these patients is when they have persistent ongoing hematemesis, that you're worried that they're going to aspirate. Patients who are encephalopathic, so Variceal patients where they really cannot control their airway, or they really can't control their airway for some other reason and you think they are at high risk. And then in that situation, you'll have the anesthesiologist, you'll do it in a controlled setting, they'll intubate the patients, but then once it's done, they should be extubated as soon as clinically possible.
Or maybe even if the patient is not intubated, the anesthesiologists are responsible for the sedation, because if something happens...
Absolutely. And if something happens, they can intubate the patient, they're right there with you. So if they're not intubated, you still should be doing those high-risk cases with the anesthesiologist present.
Yeah, because if it's urgent and it's 8 o'clock, you're in a wing which is empty, you're alone with a nurse, it can become a nightmare.
I agree with you. I agree with you.
So, and I think that should be emphasized, because anesthesiology and endoscopy as a marriage which is not happen often, and they're busy with OR and saying, who are you? And no, we don't have time. And But I think we should get accustomed to have an anesthesiology team for the procedures, the routine procedures, but especially for emergency.
Yeah, I mean, what happens at my place is we don't have a specially assigned anesthesiologist, but if we have a case like that where we have to do in the OR, we know our anesthesiologist, we know who the anesthesiologist who is on call, and our on-call gastroenterologist needs to make that connection and say, here's the case, we need OR time to do this sometime in the next couple of hours.
Okay, I think we have covered the preparation and everything around. Now we are standing in front of the patient, or the nurse asks, what shall I prepare? Which scope?
So my recommendation for variceal bleeding is I usually use a diagnostic gastroscope. Because if this is going to be variceal bleeding, I like to use a smaller size scope for band ligation. I think there's better suction. Other than that, for non-variceal upper GI bleeds, I will use a therapeutic scope. So I use a single channel and sometimes a double channel therapeutic gastroscope. The reason being is the working channel size. So for suctioning, as well as if you are going to use a contact thermal probe, you cannot get the 10 French size through a diagnostic gastroscope. You need the larger size working channel. So that's why I do that. Again, that's not based on great evidence. It's more on gestalt and the art of medicine.
Suction is the issue, right? So
suction's the issue
likely
to be able to use all the tools you can,
yes.
right? So your first choice of hemostasis may not be working, so you always have to have a plan B and plan C. But that's how I approach it with the scope. When we do it within our endoscopy unit, we have everything there. When we do have to go to the OR for these higher risk cases, we have a mobile trolley cart, and we have all the hemostasis materials there, whether that includes thermal probes, through the scope clips, over the scope clips, needles for injection, a band ligating device if we're going to be doing a band ligation of esophageal varices, or even injection therapy of cyanoacrylate glue for gastric variceal hemorrhage.
But back to the scope. You mentioned the double channel scope, which is not a very frequent scope. There is this large scannel scope, 6 millimeters from Olympus, but that's not frequent either.
No, I've never used it. We don't have that. We have a double channel, but we don't have that large super channel.
Yeah. But so suction doesn't seem to be so important for you if you say variceal and normal channel and there's blood everything and there is blood everywhere?
Hopefully with the vasoactive agents that you started before, you're not going to have that situation. I'm not saying that doesn't exist, but you do significantly decrease the chance of having active bleeding and having a real messy field if they've been started hours ago on a vasoactive agent, whether that's terlipressin or whether it's something else.
So that has become rarer, much rarer.
It has. I mean, I remember the days when we didn't have those vasoactive agents. And I remember the days when we had single shot band ligating devices with a black cap that you couldn't see anything in as you go back and forth in the patient. So this younger generation, they don't know how good they have it.
Okay, so that's kind of reassuring because I think when I remember my young days, this was a nightmare, variceal bleeder, and logistics were not ideal, and so things have really improved. Right?
I think so. I think so, and even not as much as the emergency situation, but you also know we now can treat gastric varices with EUS guided treatment using coiling plus glue. Usually those cases are not being done at 2 a.m. and it depends who your on-call gastroenterologist is if they have experience doing EUS. So that's limited. But when you do those cases during the daytime, that is also a treatment option.
You have more options.
Yeah.
Okay, so we are close to starting endoscopy. Did we forget anything to mention for preparation?
We've sedated the patient. We've given them erythromycin. We have hemodynamically resuscitated the patient. We're pleased right now. We've given them antibiotics if they're variceal bleeder. And now we put in the scope.
Okay, so that's the cliffhanger. Thank you very much for this episode. We'll be back.